Our next speaker, who's going to talk about application of psychosocial theories to understanding adherence, is Dr. Carla Boutin Foster. She's the Associate Dean of the Office of Diversity, Education, and Research. Please join me in welcoming Dr. Carla Boutin Foster.
Thank you, everyone, for inviting me to this interdisciplinary dialogue on adherence. So I have no conflicts of interest to disclose. So the learning objectives. So at the end of my 15 minutes or so, the audience should be able to describe the consequences of non-adherence using hypertension as an example, and to also understand and apply some of the social science theories as a framework for describing the psychosocial context and cognitive determinants of medication non-adherence. So what is adherence? Dr. Lewis already alluded to this, that adherence is the extent to which patients take medications as prescribed by their healthcare providers. And as Dr. Lewis previously said, we've moved away from the term compliance, which suggests that the patient is passively following the doctor's orders and that the treatment plan is not based on therapeutic alliance or contract established between both physician and the patient. And when you think about adherence and compliance, on face value, they really don't sound that different. And what Dr. Margaret Kaplan is advocating for is if we move towards a concept and a construct of patient engagement and activation. So why are we discussing adherence? What is the significance and what is the premise for this talk? Well, non-adherence accounts for about 125,000 deaths annually. We know that 20 to 30% of medication prescriptions are never even dispensed. In fact, patients don't take it to the pharmacy, right? So check the garbage cans in the doctor's office. You'll see, a Metro card and medications that their intention is never to fill it. Approximately 50% of medications for chronic conditions, in particular cardiovascular conditions, are not taken as prescribed, and 30 to 60% of the medication-related hospital admissions are due to non-adherence. So if you think of patients coming in for CHF, patients coming in for hyperglycemia, or with cardiac arrhythmias from end-stage renal disease, it's likely attributable to non-adherence. And the resulting cost is about $100 billion. Can you even count $100 billion? And yet we're contributing, both providers in our role and also in not helping patients to the best of our ability, contributing to this $100 billion cost. So the significance of non-adherence is particularly relevant for racial and ethnic minorities in the context of hypertension. Okay, do this right, yes. So African American adults have a higher prevalence of hypertension. We know that compared to other racial and ethnic groups, as well as compared to whites. African Americans, as a result, experience higher rates of comorbid conditions such as fatal stroke and 4 times the rate of end-stage renal disease. And a major contributing yet modifiable risk factor is non-adherence. And the thing about health disparities is, yes, there are a lot of immutable risk factors for health disparities if you're talking about epigenetics, but a lot of the health disparities are due to things that we as a community can address on our own. So a lot of the factors that contribute to health disparities in cardiovascular disease, in particular hypertension, are modifiable. So everyone has experiences with non-adherence. So I want you to raise your hand, and I'm going to be HIPAA compliant, so you don't have to disclose what you're on or what you're taking it for. But if you or someone you know is taking a medication or has taken a regularly prescribed medication, ever, raise your hands, up, don't be shy, don't be shy. Okay, keep your hands, keep your hands up, right? Now, keep your hands up. Your hand should stay up only if you've never missed a dose and if you always take the medications as prescribed. Wow, okay. So fewer hands are up. And the thing about it is providers may not know this, right? So we think it's important for physicians coming up, early physicians, to understand the challenges that patients may have with adherence. So what we did just a few weeks ago with the first year PBL class, right? Yeah, hi. The first year PBL class. We introduced students to the concept of adherence. So we told them for 6 days, beginning on Tuesday, ending on Sunday. Take the pink pills twice daily. Take the orange pills once daily. Take the green pills twice daily and the yellow pills 3 times daily with meals. And this is basically, they had candy. No, we're not prescribing students medications, okay? Just to let you guys know, we're not doing that. But we gave them little candies, right? Sweet tarts, I think they're called. Now, I think we have about 180, 190 students in the classroom, in the school, the College of Medicine. All students acknowledge, yes, we got the assignment, you gave it to us, and yes, we got the prescription, right? Only 5% of the students completed it for the total duration. In fact, most students said they gave up after the first or second day. They just gave, and this is candy, people, right? We couldn't get them to take candy, right? And these are some of the comments that they said. The first challenge was motivating myself to adhere to the regimen. I sometimes would forget to bring my medications with me to school, which caused me to miss a dose. I noticed that when my pills were out of sight, I generally forgot them. Overall, this experience was very insightful in that it reinforced some of the challenges that patients encounter when trying to adhere to a treatment regimen, and I will have a greater appreciation for the challenges they encounter and will be able to offer some strategies to help them overcome these challenges. Now, the students did realize that what they experienced really paled in comparison to what patients taking medications experience. And in fact, some of them said, I didn't think it was important. But the interesting thing is that a lot of our patients that we give medications to, they don't know why we're prescribing. You tell a patient, you're taking your medication for diabetes. I don't have diabetes, I have a touch of sugar, right? Right? So they're not taking their medications for diabetes. And when you think about what the students said, and also if you think back to the schema that Dr. Lewis had, it really brings home a lot of some overarching themes of non-adherence, the lack of motivation, lack of time, perceived beliefs about efficacy, and enabling and reinforcing factors. So what I'm going to turn to now is to talk about psychosocial theories that are commonly described in the literature and that can provide a context for talking to patients about adherence and for developing research interventions in educational curricula. So several social science theories on medication adherence exist. There isn't one theory that will fully capture all of the nuances of adherence or non-adherence, and many of them are overlapping, right? So the social ecological model really sets the stage for how we should approach adherence. It's not only an individual level challenge. It involves the provider, as was mentioned before. So it's individual, interpersonal, the doctor-patient interaction, organizational, the way of how far do you have to go to the pharmacy to get your medication? Is there an inpatient pharmacy? Is there an ambulatory care pharmacy? The community, what does the community think about adherence to a certain medications? If you think about medications for mental illness and how it's stigmatized, what is the role of the community in public policy? Why are people paying $300 to $600 for EpiPens, right? So what are the policies that really support and contribute to non-adherence? So medication adherence does not occur in a vacuum, and it's determined by perceived discrimination. There have been studies that have demonstrated that those who perceive higher discrimination in the provider-patient encounter are less likely to report adherence because I just don't trust you. As simple as that. As simple as that. And when we think about discrimination and bias, we don't appreciate the impact that it can have on patient outcomes. So there's access and policy and social support from family. So interventions must really promote medication adherence, must do so recognizing that adherence does not occur in a vacuum, and there are multiple factors that must be considered. Social cognitive theory is a commonly used theory. Its predecessor may have been social learning theory by Albert Bandura. Social cognitive theory addresses the social and cultural context and personal determinants of adherence. So some of the key constructs of social cognitive theory include observational learning. Basically, we're observers. We see And we do, right? Reinforcements. What's the reinforcement for taking this? Self-control. There has to be a modicum of control and self-efficacy in that you have the confidence to do it. And reciprocal determinism just says that the behavior will impact the environment, and in turn, the environment impacts the behavior. In other words, someone who's really serious about not smoking, not drinking excessively, they will not associate with the same crowd. Right? They will be active and proactive about creating an environment that's conducive and that sustains a new healthy behavior that they've adopted. However, in the wrong context, the environment can inadvertently contribute to non-adherence. You're losing weight. Why are you losing weight? You think you're better than me, or you think you're sexy now? I can't believe you're losing so much weight. You look sick. You know what people are saying about you, right? So then what happens? You know, or you're too skinny. You know, I like women with a big junk in the trunk, right? And these are loving terms that people use, and yet it may deter people from being adherent to not only medication. I know we're talking about medication, but there's also adherence to physical activity, smoking cessation, and so forth and so on. Health Believe model says, the way in which we appraise certain situations may determine how we adhere or not. So how serious is this? If I don't take my blood pressure medication, how serious is this? How susceptible am I to a stroke? What is the threat of a stroke? What will it do to me? What will it do to my family? What's the benefits of taking this medication? I heard that there are a lot of risk factors, and you really can't trust what the providers are saying. So is there really a benefit? It takes me a lot of time to go and get this medication. It costs a lot. So what are the barriers? Will this even work? I've been taking this for a year, and my blood pressure is still the same, and every time I go back to the doctor, the medication goes up. I'm on insulin now. The insulin is going higher and higher, but why is that, right? So your perceived benefits and effectiveness of the medication. And then there's self-efficacy. Can you do it? And personal modifying factors in terms of one's age, gender, race, ethnicity, culture. These are all factors that contribute to our understanding of adherence. So the stages of change model, trans-theoretical model, Prochaska and DiClemente, I believe, are well known for describing this theory. It says that health behavior does not occur linearly. So it's stages, but it's also cyclical, that you can go from maintenance back to why am I doing this in the first place, especially if you don't see immediate rewards. So the thing about the trans-theoretical model of change is that it's not linear. And it includes pre-contemplation, contemplation, preparation, action, and maintenance. So interventions have to be stage-based. You have to know where your patients are. If the patient does not believe that he or she has a problem, then to say, I'm going to put you on this medication for what? You're the problem, not me, right? So we have to know where patients are before we start giving them medications. Self-determination. I love this theory because it's simple. It says, in order for health behavior to change, the individual must own it. As Dr. Lewis said, he has to believe that he's the one who has to change. Not everyone else, but I have to change, right? So you have to own the behavior. You have to feel confident that you can do the things that you need to do, and people have to be supportive. So those are the three elements Ryan and Desi helped pioneer this concept, and it's about self-regulation and self-determination, and you're your own agent, but you have to own it. So we have to get individuals to own their condition, not to be identified by it. You know, not to say I am a diabetic and that's all there is to me, but yet I'm going to control this. I'm going to exert as much control as possible, right? So these are some new, they're not necessarily theories, but they're concepts that are really interesting in terms of how we think about patients' challenges with adherence. So the SPRITE study was a multiple trial study that looked at systolic blood pressure control, and it was a multiple telephone-based, nursing-based. And what the SPRITE investigators did was they looked at a series of questions known as chaos, right? So it's, is my life organized? Is my life stable? My routine is the same from week to week. My daily activities from week to week are unpredictable. Scheduling a meeting is difficult for me. I don't like to make appointments too far in advance because I don't know what might come up. That's what I say all the time. So there must be a lot of chaos in my life. So after adjusting for demographic, socioeconomic factors, what they found was that the higher the score of chaos, the poorer adherence. So with 1 point increase in chaos was associated with 7% increase in non-adherence. So the more chaotic one perceives their life to be, whether or not it is, the poorer the adherence. And we did a study. This was a study that we published, I think it was in Ethnicity and Disease, and it was a trial that we did to look at medication adherence and controlling blood pressure control in hypertensive. So overall, 80% of our participants were adherent. Unfortunately, there wasn't a difference in the way in between the control arm and the intervention arm. However, we did see increase in adherence. But yet, among those who were demoralized, the adherence rates were lower and the blood pressure control rate was lower, and also among those who were demoralized and depressed. So demoralization is a little bit deeper than depression. It's more hopelessness. It's a sense of no matter what you do, it's not going to work. And the interesting thing is that people who are demoralized may not necessarily think that they're depressed. But demoralization leads to inaction, right? So these are some of the findings that we saw. Self-affirmation. Now, the thing about it is Dr. Lewis said, when we tell patients to change, and that's saying something to them that something just isn't right, and I want you to change. And as adults, we do not like to change, right? As a matter of fact, most of the discussion with my husband at the dinner table is he doesn't realize that I'm right and he must change, right? So people inherently do not like to change because when you tell someone to change, it may be viewed as an affront to who they are. And it's the whole concept of stereotype threat, that people may not perform as well because they're reminded of deficiencies. And we do this unconsciously, right? So just reminding people of who they are. And again, that you are not this disease and you are able to control this. And wow, you lost 20 pounds a couple of years ago. I know you can do it again. How did you do this? So focusing on prior successes as opposed to potential failures. And in fact, there was a recent study that was done among school children and found that if you encourage them and tell them what they can do as opposed to what other people like them cannot do, they're more likely to succeed. So I'm starting to think about when I talk to my patients about adherence, sometimes I say, do you know as African Americans we are more likely to? And as I think about that, we're really setting them up for failure as opposed to we really can, and I have some amazing patients who have been able to overcome this. What are you proud of? What have you done? Excellent, you got your kids through college, all 6 of them, wonderful. Well, you know what are we gonna do to address this hypertension? So we really have to reframe how patients view illness and not do it in such a way that challenges their integrity. Culture, as someone mentioned, is very important. Who knows what, first of all, we are in Brooklyn. How many Haitians are here? Okay, raise your hand, be proud. Thank you, step by say. Okay, Haitians. Oh, see now, okay, excellent. I'm Haitian also. So much of my medication knowledge comes from my mother, who when she comes over, she's always looking in my backyard for some root or some plant, right? So I don't know, okay, here we go. What is this? Aloe, right? And this? Almond leaves. Almond, yes. My mom figured out a way of not taking her medication for diabetes by taking almond leaves until she went back and her A1C was higher than the normal level. And she was like, maybe I need to take my medications with my almond leaves, right? So she makes a tea out of it. And what about this? Ginger, right? So there are a lot of things that our patients are using that we have to be comfortable asking them. And it can be, and we often use this culture as a barrier, but it's not. It's a resource that can be embraced, right? In conclusion, hypertension contributes to excess mortality, especially among racial and ethnic minorities when it comes to cardiovascular disease and other chronic conditions. Medication adherence is paramount to reducing disparities. Interventions must be interdisciplinary, so I just love the fact that Dr. Straker, kudos to you for developing this interdisciplinary dialogue because no one health profession can do it alone. Interventions must also apply multiple theoretical perspectives. They have to be patient-centered, promote self-efficacy, reinforce social support, align with one's health beliefs and culture, and enable patients to maintain a modicum of self-integrity. Thank you.
Before you leave, are there any questions, comments? Well, I have one. Morbi, right?
What is that?
Morbi is one of the things used to lower your blood pressure.
They don't
And
have
so,
medication.
see, my grandmother, well, they have it in Barbados.
They have it in Barbados, okay.
So, my grandmother was famous for giving us
drink?
all, yes, well, it's a bark, and then you boil it, and then you drink it. So, how many people know about that?
All right.
Okay, all right. So, are there other questions? Just 1 minute.
So I'm thinking as a provider, and I'm at Harlem Hospital, so I deal with a lot of that cultural. And so do you think that also we can recommend our patient, because I know that that cultural part, and I see them coming with all these bags of different things, showing me and saying, doctor, I take this, I take that. So at times I try to tell them, even though you're using, whatever mix-up they get in every way, maybe you can also try to, because we don't know what is interacting with the medicine, but I try to explain to them like the physiological, how medication work as compared to these herbal or whatever you might mix up and bring in. It's not the same effect. And sometimes that really comes across to them like, oh yeah, doctor, yeah, that's true because I feel this way. So maybe because we know the culture is really built in. I mean, part of my family is from Jamaica, so my grandmother always gives all these, I don't even know what they are. She said they help this and that or whatever. But somehow I think that that culture part play a lot, because I try to tell them, well, if you're going to stroke out in the ED or something, that we can know what medication to work with. So I think that we really need to get that across, because that is so deep, especially in certain area where you're practicing. That really makes sense.
I totally agree with you that it is. And that's the whole concept of cultural competent care and teaching our providers cultural competency, that it's not always them against us, really, in that culture can be embraced and learning about what patients do. And a lot of patients on alternative medications, but they're not necessarily alternative, they're traditional. We call them alternative medications, but they're really traditional medications. So I totally agree.
Thank you, Carla, very much for the talk. One of the areas we're having problems with is immunization adherence. Could you make a comment on how we could get it up using those social and ecological theories?
I think immunization, health belief model is a nice construct to address immunizations. So it's really understanding what is the person's perceived, like if you do not get measles, mumps, and rubella, if the child doesn't get measles, mumps, and rubella, or what is the seriousness? What is the threat? That what do you understand will happen? And it's really getting the parent in this case, or maybe adults with the flu vaccine, to first understand, things like you will not get the flu from the flu vaccine, and what is the seriousness? How susceptible are you to getting influenza? Not only you, but as a healthcare professional working with other older adults. So I think understanding their knowledge of the vaccine, how susceptible they are to not getting the vaccine, the benefits and the barriers, and then working together to come with a solution. So I think understanding their health beliefs around that is really important.
You have to, from the School of Public Health. So is there I know there is a need for immunizations. Everybody understands that. But I'm not sure that we're doing enough to educate the public on what it means to have all these immunization schedules completed. Do you know anything about any organization involved with this campaign, educational programs that would allow specific communities to actually be more knowledgeable? Because I know the immunization problem is a problem overall, but minorities are the ones that are actually more affected in this equation than anyone else. So the question is, what are we doing? Because the only thing I see on TV is negative. In other words, somebody is saying it's not good.
No,
I don't see that people are saying, okay, you have to have regular checkups and you have to have your regular immunizations because this is the benefit. I don't see that at all.
No, that's a great point. I mean, local pharmacies are trying to do things with the flu vaccine, with demonstrating that it's okay. But I agree, we definitely should do more. Dr. Sweeney, in terms of the public health thoughts, what are your thoughts?
Yes, I want
That's a great
to
question.
bring up two issues with immunizations. A lot has to do with having a relationship with the patient and having the patient trust you. So our commendation at Bedside Family Health Center that was presented to me by Tom Frieden, of all people, because over 90% of the seniors in our health center were immunized against flu and pneumonia. Now, they knew the doctors. We also had an active program. We also had a video We also had a questionnaire to address it. We had people standing in the waiting room talking about the value of getting your immunizations. And then when the patient came in, they had an opportunity to express why, if they didn't want to accept it. And then the final straw was, I would say, I know that you would never sue me if you ended up in the hospital with complications of flu or the pneumonia. But your family would say, my mama is up in that place every year. Why didn't she get her shot? So all I want you to do is just sign the paper that said, we offered it to you and you refused it. That got the last 5%. So Dr. Frieden took that form back and put it on the Department of Health's website. So you have to use multiple approaches, and you have to take a lot of time and a lot of education, but it can be done in our community.
And another thing, Dr. Sweeney, it's not only because we know that there may be a lot of distrust between the provider and the patients, but it's not only providers saying it, it's who else they're listening to. Who will people listen to? A lot of people will listen to their imam, rabbi, and priest. So engaging places where people go to frequently and hearing the message that it's not incongruous with your faith. So reaching out to people outside of the healthcare, and I think engaging faith-based leaders to discuss with their congregations that vaccinations is something that has health benefits. So that's another route.
The questions, comments?
Hi, my name is Melinda Vargas. I'm a community health worker from Canva's Eye Care program. And when you were speaking, one of the things that popped in my head was a lot of the people who take metformin for diabetes, but they don't eat because they don't want their sugar to go up. So one of the things that we usually do is we usually go to their homes, or we speak to them in the office or over the phone or text message. And we talk to them about the importance of eating while taking this medication, because this medication is not going to work unless you eat. And the importance of, if you don't eat, when you finally do eat, your body's going to store that, and that's what makes your blood sugar to go up. Another thing with the immunizations is we work very closely with Healthy Families Nursery Partnership and these other programs, and they actually do go to the home and speak to them about the importance of doing the immunizations, as well as the breaking down the barriers on their side effects. Because a lot of times what happens is there's a lot of information out there about immunizations causing autism and other things, and we debunk that information because a lot of times they don't know that this research was done way before and it didn't have any facts behind it. So we're there to basically become that bridge between the doctors as well as the patients.
It's important also in your healthcare setting to have a champion, because 2 years ago, the Department of Health said that all pregnant women are supposed to receive the Tdap. And we had one nurse who worked there at the time who convinced scores of patients to have that Tdap. That nurse left, and we have a lesser compliance rate at this point in time. So in addition to the providers, the physician providers, the nurse providers speaking to the patient, actually one person there has to really be the cheerleader. We had a patient who came to us from pediatrics. She was seeing us in OB, she was pregnant. She refused to have the shot, but she went to the pediatrician, and the pediatrician was so upset, she started to cry, and she ran back over to us to get the shot. So it's the passion that the doctor showed her, that she was really worried about her, that made her come to get the shot. So you really do need to have a champion in your midst, in addition to everybody else educating the patient.
Someone just asked me if I was related to a teacher I had in elementary school. So, I just wanted to, we have another comment.
Early in your presentation, you mentioned the medications or the prescriptions that are not filled. And I think in that perspective, there's a lot that can be done. I don't know all the answers, but each one of us may be able to do something as an advocate. Very briefly, I would like to explain something that happened to me on 2 occasions. I was on a board with a volunteer organization whereby medications were disparately dispensed. And also I frequent the pharmacy that when the patient would go in, they would not really want to accept their medication because they felt that the medication was not appropriate for them. And so in that case, they would walk out. So what I did is I kind of spoke to the client. I spoke up as a healthcare provider and tell them why was it important if they did not wish to take that medication prescription, that they should then communicate with their physician. In addition to that, I also went further in terms of legislature and in terms of making certain that that particular pharmacy did not dispense disparately. And needless to say, that pharmacy then moved out of that particular community. So we need to make certain that we are speaking up for the clients and helping the clients to do things that they may not know that they have the right. And one thing that I can constantly tell the clients who get medication, when they sign that when they tell them, you're getting this medication and you must sign, they're signing that medication has been explained to me and I understand, but in reality, they have not told the client anything.
That is true. That's a great point. And there's another, it's not a theory, but it's a planning model, predisposing, enabling, and reinforcing. So we do need reinforcements throughout the healthcare system. So going to the pharmacy is really important, especially when people may go to the same pharmacist over and over again. So to have the pharmacist play a key role in adherence. Absolutely. That's a great question, and it's multifactorial. It stems from, if we go from the perspective of the provider, it's lack of cultural competence and providers not necessarily meeting patients where they are. It's unconscious bias, not escalating doses or providing patients with additional information that will help them. It may be the provider may feel that the patient may not understand. If you look at the patient-related factors, there are a lot of social determinants of health. There's access to care. There's also interaction. When you go to see the pharmacist, how you're treated, there's trust, perceived discrimination. Cost is a factor. However, studies that have been done at the VA where medications are paid for, and this is before Affordable Care Act, showed the same difference. So I think for racial ethnic minorities, there is the cultural factor, but there's also the interaction with the providers and the trust. There's also language, and it's not only that the patient does not speak our language. How many of you, we have so many Haitian patients in Brooklyn, and yet not many of us speak Creole fluently or Spanish fluently for that matter, or Urdu, right? So it's also the providers not speaking languages or not having access to competent translators as well. And then there's also belief systems in terms of what will this medication do for me, and priority and time and chaos. And I'm not saying that racial and ethnic minorities are chaotic. However, because of a lot of psychosocial factors that we're confronted with, medication adherence just becomes something extra. We provide medications as if I'm not doing anything all day except for taking medication, so bring it on. But there's also going to school, picking up your kids, trying to make sure that your kids aren't hurt. There's violence. There's all of these things that the racial ethnic minority communities are confronted with, that when you add medications to that, medication adherence may not be a priority, especially for conditions that are silent, like hypertension. You don't know you have diabetes until you have diabetes. So there are a whole host of psychosocial factors, and that's why the social ecological model allows us to look at it from the individual factor as well as policy, all the way through policy. So there's a whole host of factors that disproportionately impact communities of color and immigrants as well. So that's a great question. Thank you.
Hi, my name is Narsha. I'm a new grad nurse here. Just to kind of ask, there's been several instances where, as a nurse, you go up to a patient and you ask them, have you been taking your medications and whatnot, and the patient will say either yes or no. And then at time of discharge or even upon admission, you go through medication adherence, you highlight medications that you need to take and the side effects of them and when you need to take them and whatnot. And a lot of things that I've noticed was even despite patient education and home care and whatnot, patients still come back because they're not adhering to medication regimen. And I'm just thinking, I've always thought, what more can we do? And I don't know, because we've done the whole patient education, we've done the nursing care, we've done the phone calls. What more can we do to have them own up to their health condition and taking medications?
I mean, that's a great question, and I think Dr. Sweeney alluded to that medication adherence does not only occur during the provider, nurse, patient encounter at the time of discharge, but it also occurs at home. So you may prescribe the medication in the hospital, but the decision whether or not they're going to continue to take it occurs at home. So perhaps speaking with a family member if the patient gives you permission. Identifying who else in the community do you speak with. Calling the pharmacy, calling the patient back. What I often tell residents is that provider-patient encounter does not have to stop at the provider-patient encounter. Call the patients. How are you doing? How is it going with the medication that I prescribed? Have you been taking it regularly, every day as prescribed? What are some of the challenges? Okay, so I'm going to check up on you again, and we can discuss. So I think it's prolonging the discharge planning after discharge also.
Hi, my name is Marie Vincent, and I work for HCC. I just wanted to thank you very much for your presentation. Really well spoken. I've learned a lot. What I wanted to chime in on was with the immunization. For instance, I went out and did outreach for a pop-up flu shot that we were having, and also to promote the fact that we do free HIV testing. While going out, I was under the impression that once I started talking about HIV testing, everyone would get scared. But then with the flu shot, everybody would show up. Once I mentioned the flu shot, it was like, no, I don't want to do that. I don't want to. But HIV testing, they were okay with it, and it was like it was mind-boggling to me. I was like, really? And so I started asking questions. What's going on? Why wouldn't you want to take the flu shot? Oh, no, I don't want to take the flu shot because I already know they're just experimenting on us, on all that. So in regards to this gentleman's question, in regards to, the minority groups and the Caribbean, what is going on? How come, people are not adhering to that? It's because a lack of trust. A lot of patients believe that the doctors have some type of, like a contract with the pharmaceutical companies. So I don't need this medication. They're just making sure that they give it to me so they can make their money or whatever with the pharmacies. And when it comes to the shots, they're just experimenting on us. So this is what they believe. So it goes back to what you were saying in regards to trust. There has to be real trust, because even if they say, I'm going to take the medication, once they leave, you're going to throw it away because they're like, you're not going to experiment on me. I'm going to stick to my ginger tea when I have the flu because that worked for my family. And I'm going to continue that tradition, and it's not going to cause me to have kidney failure or whatever else that they believe. So I think that, establishing a real sense of trust will make it easier for the patients to take their medication.
I think you're absolutely right. I think my mom thinks that I work for the pharmaceutical company part-time because I'm always telling her to take this. But I think we really have to appreciate that it's not all about the patients, and that there is a historical context for this trust. And I don't want any of the students to think that as racial ethnic minority or who may not have my best interest at heart. So there is a social political construct that underlies adherence as well.
I would like to give a big hand to Dr. Boutin Foster because that was just a great presentation, and I'd like to thank the audience. The interaction is wonderful.